Nu går vi live här då, Kerstin. Så börja när du vill. När klockan har slagit 1, som någon minut.
Okej. Så, hej och varmt välkomna till eftermiddagens konferens om ofrivillig ensamhet. Jag heter Kerstin Tillander och är initiativtagare och huvudarrangör av konferensen. Och jag leder nätverket Stoppa ofrivillig ensamhet, som är ett nationellt nätverk som för alla som arbetar eller som vill arbeta med att minska ofrivillig ensamhet i samhället. Och det är ett forum för att utbyta erfarenheter och sprida goda exempel och lära av varandra. Och vi har funnits ungefär 1,5 år. Och det här är då första gången som vi samlas i ett stort möte. Och vi hade egentligen tänkt att ha haft en fysisk konferens. Men då på grund av covid så har vi ställt om till en digital konferens istället. Idag ska vi få lyssna till 2 brittiska föreläsare som har betytt väldigt mycket för mig och som faktiskt är grunden och startskottet till att jag blev intresserad och började engagera mig i frågan om ofrivillig ensamhet. För att jag såg en väldigt intressant dokumentär om just Frome-modellen som vi ska få höra om idag. Jag vill rikta ett stort tack till Centralförbundet för socialt arbete som har finansierat den här konferensen. Och även ett stort tack förstås till tankesmedjan Arena Idé som är medarrangör. Och särskilt tack till Lisa Pelling som har velat samarbeta med mig i den här frågan. Ända sedan början av 2019 när vi arrangerade ett seminarium tillsammans. Det är jag och Lisa som tillsammans kommer moderera under den här eftermiddagen. Och jag ska påminna om att alla som inte har sitt namn i sin Zoom-bild, att de går in och ändrar det aktivt så att det blir lättare för oss att dela in er i grupperna. Jag ska säga lite kort om programmet. Först kommer vi då ha de här föreläsningarna. 2 stycken på vardera 40 minuter. Och sen blir det frågestund. Då får ni i publiken ställa frågor till föreläsarna. Och de behöver ni inte skriva på engelska utan ni kan skriva dem i chatten på svenska. Och sen så kommer det bli ett panelsamtal. Och sen blir det en kort paus och sen sista timmen så kommer vi då ha gruppdiskussioner. Och då kommer ni automatiskt att förflyttas till den gruppen som ni ska tillhöra. Och då är alla uppdelade utifrån geografisk tillhörighet, var man bor eller jobbar. Då så lämnar jag över till Lisa Pelling.
Och då övergår jag till engelska alldeles strax. Tack så hemskt mycket Kerstin. Jag passar på att säga att jag är jätteglad för det här samarbetet och så roligt att det är så många som uppmärksammar det. Det här är ju verkligen inte det enda initiativet som finns i Sverige kring ofrivillig ensamhet. Vi är glada att vi är en del av många olika organisationer som jobbar med den här frågan och vill gärna komma i kontakt med er ute i Sverige som gör det. Tveka inte att höra av er till Arena Idé, till Kerstin så att vi kan bli fler som samordnar och som lär av varandra. Jag är utredningschef på den fackföreningsnära tankesmedjan Arena Idé. And now I'll switch to English because we have 2 very prominent guests from the UK who have agreed to join us here today and share with us some very important experiences of working with loneliness and working with a model that has come to be known as the Frome Model, but also an approach that could be called the compassionate communities approach. But before I leave the floor to Dr. Abel, who will tell us more about this in just a second, I'd like to tell you from the UK who's watching and who's here. So we have well over 100 participants here at this Zoom meeting, and we have another few joining us in the live streaming on Facebook. And as I said, there are many people in Sweden who are involved in these issues. Some of them are professionally involved. So you have sociologists, you have fellow physicians, you would also have people working in other capacities in primary care in our local health centers. But you'd also have a lot of social care workers, sociologists of different kinds who work with elderly people, with homeless people, and all kinds of issues related to this topic. But this is something more than just a professional issue. This is an issue that involves people in the broader civil society. So you'd have people who join us today, everything from guides to natural experiences, people who take people out in the forest to have them experience something together, people who work within adult education, informal public adult education, who've recently run a huge project on these issues, also with us listening today. And they will be able to listen to your talk and ask questions in the chat. In this direction, I think you will find it, all of you participants. If you feel uncomfortable asking questions in English, you're more than welcome to ask questions in Swedish, and I will translate them. So now to you, Dr. Julian Abel. You are an expert in palliative medicine. That's how you started, but for the past few years, you have worked at the medical practice in Frome, where you have developed a compassionate community approach to these issues. You are also the author of a book that was released earlier this year together with Lindsay Clark, and I just saw that it is actually available in Swedish bookstores as well. We will share the link for those of you who will do a more thorough reading about this approach and this idea. The book is available to be ordered from Sweden as well. I won't take up more minutes now. Julian Abel, the floor is yours. Please take the floor.
Well, thank you very much. And thank you for inviting me to speak. It's a pleasure and an honor to talk to you all. And what an incredible combination of people you've got. It's very wide-ranging. So you've done a great job in organizing this. I'm going to talk about if you like, with some background as to why this approach is so important, and then the creative, imaginative, and kind Jenny Hartnell, who leads the community development service called Health Connections Mendip, will talk about the community development side of things. And I also have to pay tribute to Dr. Helen Kingston, who was the person who had the original idea and had the wit and the imagination to get all of this going in Frome. I didn't actually join in my own small way until a later date. I'm going to talk about compassion first of all, and why compassion is such a good idea. And I'm going to talk about it in terms of these 4 different points. And the first is this, and I always start with this slide because it's so informative. This is a slide showing the impact of different kinds of intervention on our risk of dying prematurely. And what you can see is that the top 3 bars in red are more effective at keeping us alive longer than giving up smoking, drinking, diet, exercise, and anything else that we care to mention. And I've highlighted the drug treatment of high blood pressure down the bottom because so much emphasis is put on treating high blood pressure. If you go to your doctor, the chances are you're going to have your blood pressure checked. And if you haven't had it checked, then maybe you should go and get it checked. Although, actually, if the doctor is going to use what's most effective, use the best medicine, then social relationships come first. And if I were to ask you all about how many times you've had your social relationships checked, the answer would be either none or a very small percentage. But of course, if you have good social relationships, your blood pressure is going to come down. So this is really about what you see is that that social relationships have an absolutely profound impact on our health and well-being. So much so that it keeps us alive for longer. So how does it do this? Well, it does this through acting on our physiology, our biochemistry, our social behavior. It doesn't matter. Wherever you think about human beings, you can see the impact of social relationships. And the foundation of social relationships is compassion. If the person that you're talking to doesn't care about your welfare, then the friendships are not going to go very far. And actually, when you look at the biochemistry of this, there's one hormone in particular which plays a prominent role, and that's a hormone called oxytocin. And you find oxytocin, the so-called socializing hormone, throughout the animal kingdom. In fact, you find oxytocin receptors in all animals with backbones, including fish. So all of these animals have social behavior embedded in who they are as part of their survival. It is an evolutionary pressure. And in fact, human beings are the most social of animals. And we are unique in not just that do we all have this compassionate potential, but we also have the power of choice. We can choose to be more compassionate. And in fact, the term survival of the fittest, which is one that has been bandied around for the last 150 years in relation to evolution, it couldn't be further from the truth, particularly towards human beings. That actually there's increasing evidence to show that it's survival of the kindest or survival of the friendliest that made the biggest difference, in particular to humans. And actually, up to about 1 million years ago, there was more than one kind of human wandering the planet. There were at least 6 different kinds, but by the time we get to 100,000 years ago, we're the only type. And it seems that the thing that made the biggest difference is our ability to cooperate and share. So survival of the kindest is a much more appropriate term. The third reason to continue on the second reason is the Harvard and Glueck studies of adult development. And these are 2 extraordinary linked studies which followed the lives of men initially from 1938 onwards. They started with a group of men from Harvard University, but they extended it into the poor areas of Boston, and they followed these people's lives, and the study is now into the 2nd and 3rd generations. And Robert Waldinger is the 4th study leader. And what he says is that there was a strong correlation between men's flourishing lives and their relationships with family, friends, and community. And it's a quality of those relationships that makes all the difference. And the key message from this is, if you want to lead a healthy, happy, long life, it is all about compassion and relationships. And the 3rd study leader is George Valen, and he emphasizes the point by saying numbers 1, 2, and 3 are relationships, relationships, relationships. The third reason why compassionate communities are so important is because when you look at the impact of loneliness, it is profoundly negative. That if you're feeling isolated, it increases your risk of dementia, increases your risk of heart disease, increases your risk of mental illness, including depression, anxiety, and suicide. And if you're already ill and if you suffer from loneliness, actually, then your chances of being using hospitals are hugely increased. And we have to think about loneliness as not being something that just affects the elderly. This is something that can affect from the young to the old. And in fact, when you look at it, human beings, from the moment we're born to the moment we die, seek the presence of good social relationships. And when they're not present, we feel lonely and isolated. And it's easy to see how, for young people in today's modern world, how they can become lonely and isolated, particularly when you think about so much of life is online. It's not direct face-to-face contact. And that negative things that happen in school or in our educational institutions go on when somebody gets home. It never stops. So you can see that actually loneliness has a profound effect on our health and well-being. And then the fourth reason is what happened in Frome. And one of the unique things about Frome is that we had these really extraordinary outcomes which we were able to measure. So this is a chart showing emergency admissions to hospital across the whole population of Frome, a town of 28,000 people in the county of Somerset in the southwest of England. Somerset is a county of 500,000 people. And when we were trying to work out what the effects were of the intervention that had been put in place by Jenny and by Helen, we discovered that the emergency admissions across the whole population of Frome had gone down by 14%, whereas in Somerset they'd gone up by 29%. And we knew that there are no interventions ever that have been successful in reducing population emergency admissions. If there was a tablet that could reduce emergency admissions to hospital by this amount, it would be a medical miracle of that we have not seen before. It is absolutely extraordinary outcomes. But you have to remember that this wasn't the aim or the original intention of the project. The aim was to provide the best treatment for people through making use of the things that are really important in our lives. In other words, our relationships. That health and well-being is not simply the absence of disease. It's not simply the good control of symptoms, whether these be physical, social, psychological, or spiritual. Actually, health and well-being, the reason we live, is about the things in life that are most meaningful, most important, most joyful to us, and for most people. When you ask them about what makes the biggest difference, what matters most, it's all contained in our relationships. And that may be relationships with the people who are around us, but it's also the relationships with the place in which we live, work, sleep, etc., etc. So what you can see, what we're getting at is when you think about those four reasons about why compassion is so helpful, why relationships are so good, in a way, it's no surprise to see the outcomes that we got in Frome, because we have tapped into something which has not been a mainstream part of both our communities and our medicine. That what's happened is that we have made best use of compassion and social relationships, and the impact of that is transformative. So what we're saying is that this is a new dimension to medicine. If we want to practice the best medicine, we have to make sure we use the best therapeutic tools. And this is not something that is applied just to individuals. It's applied across whole populations. whether it's your town, your neighborhood, your county, your district, your country, it doesn't matter. It's when we're thinking about how you implement this, there are two really big components. One is what happens in relation to healthcare, and the other is about what happens in communities, which we've termed compassionate communities. And we can see that the application of this is not just about elderly people or people who are unwell, because the joy, the love, the laughter, the friendship is something that's applicable to all of us. And that's the thing that gives us health and well-being. And this is not solely a medical intervention for people who are sick, but from the community aspect of it, it's about making sure that there is a unified approach between communities and medicine. And the other key component to it all is about how we bring about that change, because the change has to be developed from within primary care. The medical side of it has to be the people who are doing the work. And likewise, the community side of it has to be done by communities. This is not something that is done to people. It is something that communities do themselves, sometimes with help and support and sometimes without. And it's useful I'm going to talk more about the medical side of things now, and I'm keeping a close eye on the time to make sure I don't go on and on forever. It's when you're thinking about this from the medical perspective, then you can think about it in terms of what happens with high blood pressure. So what happens with high blood pressure is that there is a screening program that people go to the doctors, and as often as not, they'll have their blood pressure checked. Not because the doctor is thinking that everyone's got high blood pressure, but because the doctor wants to know which people have got high blood pressure so that they can give the best treatment to reduce the blood pressure. Because even though the effect of treating the high blood pressure is not as great as using social relationships, it still helps to reduce your risk of death. So once you've diagnosed high blood pressure, of course, you make sure there's nothing more serious underlying. Then you prescribe a treatment and you follow the patient up. So what you do is you prescribe a medication, and it may be that you will recommend some lifestyle alteration as well, although that's definitely a tricky subject, telling people what to do. But you give the medication and then you follow up. And the follow-up doesn't mean that every time somebody has their blood pressure checked, that they have to go to the doctor for the doctor to do it. It can be done by the whole team, and people can do this at home. But you definitely want to know whether somebody's blood pressure comes down. And that is a whole team, a whole practice-based intervention. Well, you can apply the same principles with social relationships. Remember that we want to use the best medicine. So the way that you can think about this is to make sure that there is some kind of assessment about what matters to people and what's most meaningful in their lives, and have they got this sense of loneliness, and are they connected to the people around them, and who are those key people. And then you can think about, okay, well, look, if somebody is not entirely happy on that level, what can be done to help them seek a solution to that sense of loneliness? And that's where the whole community development side of things, which happens inside the GP surgery, works. There's a variety of different solutions, but you apply that, and you'll hear those from Jenny, and you'll apply those solutions, and then you'll follow up to see whether things have improved. So from the medical side of things, you can think about how you put this into routine clinical care. When you come to think of the types of solutions that people have, then you can think about all of the resources that are currently present in the community. And in all of your communities, there are hundreds of different things going on. Whenever people come together, they do things together. And I think perhaps that's the essence of it. When you're thinking about health, when you're thinking about solutions, you're not thinking about somebody to go away and improve their lifestyle in a corner on their own. It's all about how it's linked up. So if you've got the community resources to hand, you can then think about how you connect people to those community resources. But for many people, that they don't have the understanding or the confidence or a whole variety of other reasons why they may not want to connect with their community. And this is where the one-to-one work of the health connector, somebody who is not a health professional, but somebody who's trained in motivational interviewing, will help. And that happens again, can come happen within the GP surgery or can come from the community side. And Jenny will talk more about that. And then the other key bit, which is about people's own personal networks. And we can all think about our own personal networks. Who are the people that matter most to us? Who are the people where the love, laughter, and friendship takes place? Who around us? Who are the close people? Who are the people that are friends but not quite as close? And who are the people in our neighborhood that we meet on a regular basis that we feel happy with and we just chat to? Because the heart essence is contained around the people we know and love. And so making some kind of assessment to see what's going on and seeing what we can do to bring that community of people together to enhance what's going on is absolutely central and key. In the context of what happens when you're thinking about how you change your GP surgeries, your primary care services, then you're thinking about identifying those people in need of support. And that means having some kind of assessment around social relationships. And then there's a conversation about what matters most to people. And the setting up of the hubs inside the GP surgery, that means that you can follow the development of what's happening to people across the whole practice. And that includes multidisciplinary team meetings, administration support, and the closeness of the community development is embedded in the GP practice. And then we talked a little bit about enhancement of the naturally occurring networks and the linkage to community resource. But if you like, that's the whole process. So the essential architecture of the model is internal hubs inside the GP surgery, community development, which happens in the GP surgery and in communities, and then your tool for change. How do you bring this about? This is not a top-down initiative. This is not something in which people are told what to do. This is all about how people can work it out for themselves. And the place to start is around relationships. If the relationships are not right, then it's inevitable that this doesn't work. So, and it's not relationships just within teams, it's across teams, across organizational silos. It's very easy for health services and social care to become isolated and separated. But when you actually start communicating together, the difference is transformational, that you suddenly work out problems that were previously full of administrative obstacles, and people sort out how they work together themselves. We know that if you want to get the changes that we're talking about, the reduction in emergency admissions, then you have to implement all functions of the model. Just doing it piecemeal doesn't work. The order in which you do it doesn't matter, but you have to build up. You have to make sure that you include everything. The ownership of the change must be with the people who do the work. This is, just to repeat this again, this is not a top-down initiative where people are told what to do. And no identification criteria is all about thinking about how do you assess the social relationships aspect of whether people need help and support. And then you focus your care on do what's best for the patient. And we're going to talk a little more about quality improvement, not too much. And then we have to think that the community development worker is part of the clinical team. How do you bring community into the GP surgery? And how do you get the best of the quality of relationships that the community development worker will bring is by having them there when patients are discussed. It's an absolutely critical component. So it starts with what our basic aims are, and our basic aims are improving patient care, reintegration of people into the community, reconnection of that person, reconnection of the individual, and that in addition that we look at improving working lives. That we've heard this story again and again, that the staff, the health and social care staff who are involved in these projects say, this is why I came to work in the first place. But one of the most, I guess, you know, from my own personal perspective, that there are two really difficult things about being a health or social care professional. The first is, of course, the difficulties of dealing with huge administrative organizations, which have a very strong top-down push that actually somehow dehumanizes people and doesn't respect the opinions and the knowledge of the people who do the work. But the other really difficult thing is when people come to you seeking help for the relief of suffering. And if you don't have the tools at your fingertips to help relieve that suffering, you just see people continue to suffer. And that is distressing. And if you bring in this whole new area of compassionate communities, of compassion in communities, of kindness, of good social relationships, you find that there are so many more problems that you can solve, and you regain that sense of joy about your work. And the cost savings are enormous through keeping people healthy, but it's a byproduct, and it was never the original motivation for the project. It's recognizing that people are complex, that simply a tablet is not enough to help people with their problems. And it's recognizing the power of relationships, not just for patients, but for the clinical teams that are involved as well. And that's a very inclusive definition, clinical team, because it involves anyone who is employed to help people in whatever way they need. So it's health and social care and whatever else. It doesn't matter too much. As we said, this is a whole population approach. It's done in a systematic way, and it's done in a very holistic way, and it's based on the needs of the people we find, not the needs that we think they have, but the needs that they tell us about. What is the problems that are pressing them most of all? I'm going to talk a little bit about quality improvement now, just because it's helpful to have some idea about this. That often that the changes that we've seen to healthcare in particular have come from top down and have disempowered people, and doesn't really respect the knowledge and the practice knowledge of the people who are doing the work. And actually, the people who know best how to change what's going on are the people who are involved in doing that work. And the quality improvement is a way of making sure that the people who come up with the ideas are the people who do the work. And furthermore, it checks to make sure that a change is an improvement. And if you can't show a change is an improvement, don't do it. And so many changes that have happened to healthcare actually haven't made things better. And even if you take into account that just simply the administration that now goes with healthcare, you find that if you'd thought about that at the outset, there are so many things that wouldn't have happened. And in some of the UK hospitals, nurses will spend 3/4 of their time doing paperwork and 1/4 with actually face-to-face with patients. And That's just insane. And the other component about all of this is, in the context of very complex systems, it helps to build continuous improvement and system reliability. And you can think just on a simple level that if you just applying this to a few people in the practice, you're not going to get your health outcomes that you want. But if you apply it across the whole practice, then you're going to get the population health outcomes that you want, and that you gradually build in greater and greater reliability. You build in this process of continuous improvement. And this means that for each practice, there needs to be somebody within the GP practice who leads on this and builds a team on making the changes that are appropriate for your area. The solution in one practice is going to be different from solution in every other practice. You have to understand about what works well. And then building from what works well, you start small-scale testing. And you learn from things that are not working so well, how you alter and change them, and how you gradually improve. And when you've got the thing working well, you can then think about applying it at a larger scale. But the people who build this continuous improvement are the people who do the work. It's inclusive. There are no bad ideas. We're all used to those people who say this will never work because, and actually those skeptics have a really useful point to make. And rather than saying, oh, you're just not a team player, we can turn it around and say, okay, those are really useful points. Let's see what we can do to adjust what we're doing to make sure that it reduces the chance of things not working. So you listen to everyone, and then you chart things out, and I'm not going into the detail, but you want to be able to watch the continuous improvement that's going on. And those charts that I showed you of emergency admissions, those are run charts. They're charts that are plotted over time so you can see how things change. They're really, really useful. And so the type of things you might be looking at is, for people on the service directory, but for people who are making use of the community resource, that's all contained on the service directory. How many people get signposted to that? How many people have their own networks assessed and something done about it? And how many, I've used community promoter, but there are different terms for this. Jenny will talk about health connectors, and I'm sure you'll come up with your own terms. And you can start looking at the individual processes to see whether the things that are supposed to happen are actually happening. And you can measure these in terms of numbers, but most important is that you get stories. How did it help people? What changed in that person's life? And the stories are all about inspiration. The numbers are about reasoning, but reasoning alone is not enough. You need emotion and you need inspiration. And when you hear the stories of what's gone on, that's the thing that makes the biggest difference. And so you want to make sure that you collect all of this information as you go along so you can measure the changes. And this is the type of thing that you see happening. The normal Dr. Anne Robinson is a GP who works in a GP practice in London, and she was writing about the type of person that she saw in her surgery in the morning. And for those of you who can't read English, I'm going to just read it out. In my GP surgery this morning, I had nothing to offer a significant proportion of the people I saw. People with lifelong depression, low self-esteem, agoraphobia, and anxiety who have become socially isolated. An elderly man and a young mother, both feeling the effects of loneliness and lack of social support. A man in his 60s who has recovered from a heart attack, but is finding it hard to motivate himself to overhaul his lifestyle by stopping smoking and starting to exercise and eat healthily. A young man who has back pain, for which no specific diagnosis or treatment can be found, despite extensive investigations. An elderly, frail lady who is so scared of falling that she becomes a prisoner in her own home. And you can think about what a significant role compassion and friendship has to play in resolving those problems. And I'm going to finish by quoting Dr. Helen Kingston, who started this, when she was thinking about her original motivation for this project. She wanted to create a community where people are supported to be creative, active, and resourceful in response to their own and each other's unique and shared needs, with easily accessible, integrated care and support available to all. And what I really love about this short statement is that when Helen is thinking about health, she doesn't actually use the words health or illness. This is about how we support each other as human beings. And on that note, I'm going to hand over, hopefully smoothly, to Jenny Hartnell.
Thank you so much, Dr. Abel. We will wait for Jenny to join us with her camera as well. Let me just ask one question, because I know Jenny will go into how it actually works in practice. And I think what we've heard so far is so inspiring, and I think many people who are listening who are indeed healthcare professionals would love to work in this way, with side by side with a community development worker, being able to do referrals to someone who promotes people to address their loneliness by encountering friendships, social activities. But I know that a big structural problem in today's healthcare systems, if you allow me to ask a question about on the system level, is that healthcare actors tend to get resources and instructions to deal with short-term needs and to offer short-term treatments, and not to use resources or devote themselves to long-term intervention and long-term prevention, which what you're talking about largely is. How do you address this issue? How have you been able to make sure the system works more with prevention and less with the short-term treatment approach?
So this is a really great question. And when, if we're thinking about, us as people, we want to lead a good life. And if we're thinking about health professionals, they want to provide good treatment for the people they serve. But if we're thinking about the people who commission health, they want value for money. And when you start looking at the value for money, actually the results are extraordinary. That just simply from preventing people going into hospital because they are healthier and happier, you save 5% of the total health budget. And that's simply on not treating people in hospital. That doesn't take into account the dramatic long-term transformation in people's lives. And actually, it doesn't make sense not to do this, because if you to quote Albert Einstein, if you keep on doing the same thing over and over again and expect a different result each time, that's the definition of insanity. And actually, if you want to make improvements, which makes people happy, keeps them healthy, and saves extraordinary amounts of money, then build a compassionate community program.
Thank you so much. We've received a lot of questions. One of them, but I think I will let Jenny speak first, just for you to know, kind of follow the chat in Swedish. One question that maybe you can address, Jenny, later on is, you are referring to some amazing results when it comes to healthcare and primary care. And one question that was asked is, have you seen similar results when applying a compassionate community approach also in social care, in elderly care, in other kinds of social care, this was an important question. There are more coming up, but I think we'll save them for the session afterwards. So Jenny Hartnell, you are service lead for Health Connections Mendip. And you work at the Frome Medical Practice, but you're also a senior fellow at the Institute of Social Prescribing and in southwest of England, and you've worked with this for many years now, and you've worked with it in your daily practice. Please, Jenny, floor is yours.
Thank you. Thank you for the introduction. So my name's Jenny Hartnell, and I'm the service lead for Health Connections Mendip. And Health Connections Mendip is a service that covers not just Frome, but a wider area as well. So here we've got a picture of Somerset, just to give you a picture of where it is in England. That's a population of just under 1 million. Mendip is a district of Somerset, and that's 118,000. And Frome is a town in Mendip with 30,000. So the work I do is in Frome, but also across Mendip. Frome has had a lot of the publicity, but we don't just work in Frome. So I'm based in Frome Medical Practice, so I'm sitting in this window here. And Frome Medical Practice is known as a very innovative practice. For example, we've won the Green Impact Award for being a sustainable practice and reducing things like asthma inhalers. And we've got solar panels on the roof. But also we're known for our work that Health Connections has done, which is seen as part of the Frome project. It all started with this wonderful lady, Dr. Helen Kingston, in 2013, who employed me, and she said to me, Jenny, I just want you to help me have better consultations with patients. I want to know everything that's out there in the community. I want to be able to support my patients in a more holistic way. So I gave her a 3-year project plan, and I said, I think this is how we can do it. And she said, Jenny, I trust you. She said, just go out and do that and do what you think is best. So from that very moment, Dr. Kingston gave me that gift of trust. And it was an equal relationship. I came in as a community development worker and met her as a human being, as a doctor. So straight away, she was modeling that way of working, which was, we're all in it together. And she knew she was great at being a doctor, and she knew I was great at being a community development worker. So she gave me that freedom to do what I thought was right. So that was kind of the beginning of what's now being called Compassionate Frome. In the beginning, we didn't talk about compassion or loneliness or hospital admissions. It was just two people thinking, we want to do something here. And so that's how it sort of started. So she said to me, I want to know what's out there. In Mendip and in Frome, there are amazing things going on in the community. She had information about walking groups, exercise groups, bereavement groups, but she had them all over the place. One was an email, another was a leaflet. So she said, Jenny, put it all in one place. So I spent about a year walking around, going to cafes, going to libraries, talking to people, sitting on benches, finding out what was available in the community. And I put that all on a website. And we have over 400 groups. I started, actually, we had about 2,000 in the beginning for that whole area of Mendip. And I thought, actually, I need to reduce this down to peer support groups, things that were free, things that were run by charities, not the expensive yoga classes. There was another website for that. I imagine in Sweden, as we do in England and in Somerset, you have lots and lots of websites that do this kind of thing. But what Dr. Kingston wanted was something that we were in charge of updating, that we knew was up to date, and that she had access to, and she knew it was local enough. So that website here can be accessed by anyone. So you can find out things about the mental wellbeing phone line, about the befriending group, about the Macular Society, about national campaigns. So that's open to the public. But also when a GP is sitting with somebody, a doctor is sitting with somebody, this is the patient record here. they can click on a button and it brings up all the categories on our website, and the GP can give them the information about this support. So the GP is at that moment saying to that person, there is a huge amount of support out there. Here you go. They're not saying, we think you should go to this exercise group, we think you should go to this bereavement support group. It's just that first step of saying there is support out there. This information is then coded on the GP record, so the GPs can keep track of where that person has been signposted to. So this is what we call simple signposting. Other people call it social prescribing, but that's a really simple signpost. So once again, we've got that website, but you can't just rely on a website for all that amazing information that's out there in the community. So we have a phone line, so people can call us up and say, where's the nearest bereavement group? Where's the nearest young person's mental wellbeing cafe? We put information on the radio, which is publicizing all the information that's out there in the community. We put newspaper articles in the newspaper when a service says we haven't got many people coming to our service, so we promote their service. We put a lot of information on Instagram, Twitter, and Facebook, and we have a monthly newsletter that goes out across Mendip. So that's 118,000, which is a really good group to work with, a population of 118,000. We also say it's fine to have a website, it's fine to have a phone line, but actually we need physical places where people can go to find out this information. So this is like a physical place that's instead of the website. So we have what we call talking cafes, and the talking cafes are across Mendip, and they're at the same time, at the same place, in the same towns each week. Somebody said to us a while back that it's a bit like church, that you know it's always there. And we also realised that a phone line, a website, a physical place isn't enough. That actually we want people to be passing on the information about the amazing support that's out there. Because if people are doing that out in the community and having those conversations, that person may never come to the doctor, and the doctor may never have to give out that piece of paper with all that information on it, because it's happened in the community already. So those people are what we call community connectors. So what are community connectors? Community connectors are members of the community who signpost friends, family, colleagues, and neighbours to support in their community. We might often have somebody who comes to a doctor, and actually the doctor suggests that they become a community connector. So it might be that they're not being signposted to that support in the community, but actually it might be that they become part of that solution, and that's what makes them feel like they're doing something great, that they're part of the solution, that they've got a role, and they're out there in the community supporting each other. It's 1 hour training. Everybody and anybody can be a connector. It's not a volunteer. These people aren't volunteers because we don't have the capacity to look after lots of volunteers. It's about being an active citizen. It's often part of staff induction in supermarkets, in job centres, in libraries. People actually train people up to be community connectors. So our training, we can do train the trainer, so that straight away, those people who are doing those jobs know that they can say there is support out there, rather than if only I'd known about that support. So our dream is that everybody in Mendip, everybody in Frome can become a community connector. It doesn't need to be active people who are out and about in the community talking to people. It could be this boy here who, when we had this illustration done, this was me thinking about my son. My son did suffer from chronic anxiety, and he didn't really speak to anyone, but he did speak to people online. So it's not about having to be out there in the community. You can communicate this information with people in whichever ways. We've also trained up homeless people on park benches, because actually those people might be the very best people to be talking to their friends, the people who they know, about the support that's out there. So we've trained police, taxi drivers, hairdressers, students, doctors, cafe staff, supermarket staff, parents, grandparents, homeless people, job centre staff. As I say, anyone and anyone can be a community connector, and they are basically like the website, but they're human beings passing on that information. I said here doctors. What's really important is that when doctors start off, when they start in this practice, they get trained to be community connectors. So once again, we're saying this is a really valuable skill, and it's getting that balance and showing the importance of that. We've now trained 1,500, or over 1,500 community connectors. We did that on £10,000 a year. We now have a little bit more funding, so we hope to be able to rank that up a bit. We asked people how many people they signposted. In the first year, on average, people signposted about 20 times. So with those 1,500 community connectors, they're having 30,000 conversations out in the community. So that's 30,000 times that potentially that person is being supported at the very early stage. And having that message and that support from friend, family, neighbour is probably the best way that that person might hear that information, rather than it getting to the stage when it's with a doctor. So that's our kind of community connector part of it. There are lots of people for whom a simple signpost, so all that information, the website, the phone line, the community connectors, is about simple signposting. So there are lots of people for whom a simple signpost isn't enough. That's where we have our health connectors. Our health connector, Caroline, wouldn't be pleased with this photograph, but so our health connectors, we had in 2015. So when I gave that 3-year plan, I said we would need health connectors eventually. So we did in year 2. We had funding of 310,000 to cover that population of 118,000, with all the community connectors, with the health connectors who are paid members of staff. We pay for the website, and we also pay for the integration with the GP record. So it's not a lot of money. Our health connectors are paid members of the doctor's practice team. I've been a community development worker for 30 years, and this is where the magic is. It's the magic that we're working in primary care, that primary care, so GP practices, see us as part of their team. Our health connectors listen to patients and their carers and find out what's important to them. So we have these leaflets out and about in the community that says, what's important to you? We don't necessarily want to work with those people for simple signposts. We want to work with people who've got complex lives, for whom a simple signpost isn't enough. We help them in setting goals and making changes that are meaningful for them. We help them with network creation, network mapping, and network enhancement. So that's who's your network. We work alongside the GPs. We go to multidisciplinary team meetings with them. And so we bring in that community development into primary care. And so we change from within the medical model, we're bringing in that community development. We have one health connector for 20,000 people. Ideally, I think we would have one per 10 to 15,000. And what Julian was saying before about signposting to the community, and I kind of see it as connecting, that it's that circles of connections, that actually a lot of it is about connecting to yourself, whether it's connecting to how to relax or how to tap into what's important to you. There's that level of connection. Then that level of who's in your network, your friends and family. Then the network of who's in your community, how are you tapping into the community groups. But also there's that wider level of connection of a big sense of belonging, whether that's spirituality or being a part of a sense of a movement. So I see there as being those different levels of connections, not just kind of signposting to support in the community. So our health connectors really work on all those different levels. Often we've mapped what's out there in the community, we've got it on the website, people are talking about that, having the conversations, but often there aren't things in the community. So we help people in the community set up those groups. So before COVID, we'd help set up a leg ulcer club, a chronic obstructive disease, pulmonary disease, which is lung support group, macular degeneration for the eyes, diabetes, fibromyalgia, stroke support, a group for people with dementia, a hearing support cafe. These are all kind of medical groups, well, condition specific, because lots of the other groups were already set up. Our team are not medically trained, but these are peer support groups. And we set those groups up with the community, and then they fly. So those groups become community groups. They're not under our umbrella. We just help support them to set up. We do run Health Connections groups. So we run goal setting groups. We run a healthy lifestyle program on sleep, exercise, relaxation, and we have those talking cafes. So our Health Connections and our team see people one-to-one, but we also run 402 groups a year. Those are the groups that we run, not the ones that we've kind of helped set up. Then COVID came along. And there was this amazing community action response, the same across the world. So all these groups that were out there in the community disappeared, but the community action came into force. Street groups, neighbours, WhatsApp groups, all came up and bubbled up. And I'm sure that's what happened in Sweden, that neighbours started looking after each other. Neighbours started putting things through people's doors, saying, if you need help, contact me. And suddenly this amazing community response was there. So the way we worked changed. So it was what was important to you again, but what was important to people was shopping, was medication, was we couldn't see people one-to-one. So from seeing about 350 people a month one-to-one and doing all the groups, we suddenly, in September, this is September previous year, it was 300 or so people a month. September this year, it was 1,400 people that we were supporting over the phone. So suddenly, in the space of a month, that sort of went up. And yeah, so the way we work changed. So from now onwards, I'm really going to talk about the way we work. But what was fascinating was that a huge amount of interest came in the community connector type of work that we were doing. So in the GP practice, we'd established our health connectors, we'd established that relationships with the doctors, but it was that wider community stuff that was really getting people in the community involved. So we set up something called Let's Connect, which was actually all the work that we were doing anyway, but we found that in the community, they didn't want a label of the Frome project or anything like that. So we thought, actually, what's something that doesn't have a label on it, an official label? So the feedback we had was that people wanted something like the title, Let's Connect. Let's Connect projects are simple, they involve a whole population, they're replicable, anyone and everyone can get involved, and they're cheap or zero cost. So what I'm going to do now for the next 10 minutes or so is just go through some of the projects that we do. And I'm sure in Sweden you have lots of projects like this. So it's just really an idea of what our team does now. So I've explained about the community connectors. So we have 1,500 community connectors. We also realized during COVID that we had lots of people who were digitally excluded. So we set up digital connectors. Once again, 1 hour training, anyone and everyone can be a digital connector. And it's about talking to people about the opportunities, where they can get connected, the benefits of being connected. And we've also tapped in, we've just been given all these free telephones. So we've tapped into free tablets, free telephones that we give out to people who are digitally excluded. We also realized that through COVID that the fact of having healthy lifestyles is hugely important. So we have healthy lifestyles connectors. Those are people out in the community, the same as the community connectors, who are passing on the message of how important sleep is, how important relaxation is, and signposting people to that support in the community. We have street connectors. So our aim is that in every street, we have one person who can cascade information to their street. We have green connectors. We do a lot of what's called green social prescribing. So those are people who explain the benefit of being out in the open, of walking, of nature, of saving energy. So those are our green connectors. These are not paid people. This is that 1 hour training, and these are all of us and any of us. We also have warm home connectors because we looked at the excess winter deaths of people who are living in cold homes. And planning ahead connectors. This is Julie, who is one of our team members, and she went out to a men's shed, which is a place where men do carpentry together. And they happened to be making a coffin because one of their members was unwell and said to their friends, I don't want a coffin bought from a shop. I want you to make my coffin. So these men from the men's shed made the coffin, and Julie went in and did some planning ahead connectors and showed them with this booklet the importance of thinking about what happens when we become less well, of thinking about what's important to us towards the end of our lives, and how it is important as a community to talk about those things and not wait till it becomes too late for our doctors or our consultants or our social care workers to be talking about it. Let's have those conversations in the community. So that's where we have people like our planning ahead connectors. So this is the Let's Connect training. As I say, it costs nothing to do this training. And what we found is that more and more people are coming to us saying they want it, whether they are supermarket staff or just people in the community. And also people in the community are now doing this training themselves so they can train the trainer, train the trainer. This is what we found has started to create a huge movement in Frome, that actually people really feel they're involved in it and they are part of the solution. I think you might have remembered at the beginning, we were talking about the talking cafes where people can get information. We can't meet in cafes anymore. So we set up a talking bench. And our talking bench is in response to those people who might want to come and talk to us, but also might want information that they can't get on the internet. So we have talking benches and we are there, whether it's raining or snowing or sunny, we're there on that bench talking to people, and they can come to us and ask us to be signposted to support in the community, or they can just come and have a chat. And sometimes when it's raining, my colleague and I here, Hayley, we say, gosh, was that worth it? We've got soaking wet, but we think actually people know we're there. So even if we're there for weeks and weeks and we just have nice chats with people, if we're there just for that one person who's feeling desperate and comes to talk to us, then it's completely worth it. So once again, I'm sure you might have places like this in Sweden where you can meet people out in the community. It costs nothing, just half an hour of staff time. Also, we realised during COVID that people didn't have information, so we contacted an organisation in Scotland, and they said to us, we said to them, can we use your booklet? And they said, yes, you can. So it's all about how to look after yourself and how to look after others. So they allowed us to copy their booklet, and I'm sure they would allow you to copy it if you wanted it in Sweden. And what we did is we got one copy printed for every household in Mendip. So across that population of 118,000, and we asked volunteers in our community or just community members to deliver this book. So it wasn't paid members of staff, it was volunteers who queued up to collect their boxes of these books to deliver through the doors of their streets. So that was just how we could do a call out and say, can we have some helpers? Those helpers popped up and delivered this. So it was delivered by the community for the community. Once again, cheap, easy, and helps to create that feeling of being a movement. This was before COVID, but also I spent an hour walking around Frome saying, can we do a pay it forward? So it took me an hour to speak to these cafes, and they all said, yes, we'll do it, pay it forward. So if you buy a coffee, you can pay for another coffee for the next person who comes along. 1 hour to create this. We're now creating that across the community. So recently we spoke to a bookshop, and they're doing it in their bookshop. So they are people who are buying a book, they're buying one for themselves, and they're buying another one, which they then give to us to be able to give to people in the community. Such simple, easy, cheap things, but once again, creates that feeling of us being a community, all doing things together, being kind and being part of the solution. We also had postcards that we got out and about into the community that have our details on the back. So we gave those out to community groups. It cost us next to nothing to have these postcards printed. So we have those in cafes, in shops, and people can give them out to their friends, or they can use them with their community groups to send out to their community members. We also, you can't really see here, but we've also started something called a town of names, which is during COVID, we realized that people have their masks on. And so we are getting these badges out and about in the community, and anyone can walk out in the community with their name badge on. So we give those to people. And that just, we've had amazing stories of people just talking to each other, saying hello to each other. So breaking down those barriers that there might be with the mask. Once again, it costs hardly anything. It's a whole population approach. It's easy and it's replicable. So those were all our Let's Connect training and a few of our projects. And those are just projects that we've done in the past sort of few months or so since COVID. But I'm just going to go back to our core work and just tell you a little bit of a story of somebody. We had a lady called Kathy who went to her doctor at Frome Medical Practice, and she had pains in all her joints, and she had arthritis everywhere. She was young. She'd explained how she couldn't work. She was off sick. And her doctor was thinking, and he told us this, he didn't quite know what to do because he knew that he could give her some medication, but she said actually she would like to meet other people in a similar situation. He then, a health connector, went along to visit Kathy in her home and spoke to her and found out what was important to her. And the same thing that she told the doctor, she said she really wanted to meet other people. So she went to one of our on-track goal-setting groups and met other people and started setting goals for herself. And one of those goals was to go to one of our Healthy Lifestyles group education sessions, which talks about self-management. By this time, Kathy was using a stick, literally, so she'd gone from her wheelchair. And obviously in these sessions, people are supporting each other as well. She then went on to an exercise class within Frome Medical Practice. And then she went out into the community and started doing an exercise class. She was still going to things like the on-track goal-setting group. And then what Kathy did was she became a community connector. So she then was out from this whole process. She then went out into the community and started supporting other people and signposting other people to support and telling people her story. So that's just a little story of Kathy, but Kathy sits within this community where everyone is not everyone, but you know, lots of people are supporting each other. We have these things like Pay It Forwards, like the Town of Names, like the booklets, like the talking benches that just grow up, and they're so easy and so simple to do. And so that's kind of where we are with Frome. This is happening across Mendip as well. So it's not just Frome. Frome has got the publicity about it, but it's happening in other areas. When I met Dr. Kingston in 2013, I'd been doing this in Harlesden, which is an area in London, which is one of the areas of highest deprivation in the whole of the country. So it's not, Frome is a magical place. It's an amazing place, but it can work elsewhere. So is Frome special? As I say, yes, it is. But if you're thinking of Sweden and you're doing these things, find that place that is doing it already. Find that place where there is the spark. Find those people with that spark, with that energy. Link them all up. Link up all those initiatives. Often when we do conferences, people say, yeah, we've kind of got this going, but they say, but we're not linked up. Link it up. Get those neural pathways between people, between organizations, between towns, get them going. Julian was saying about adult social care, I worked in the GP practice and I'd heard conversations about social care, and I thought, do we really understand what social care does? So I invited the head of social care into Frome medical practice to explain what they do. And then I said in the meeting, please can we have a social care worker working in primary care 1 day a week? And she said, yeah, okay. That was absolutely amazing. At that point, that person was the person who connected doctors, GPs, the primary care with adult social care. It was that relationship of her working in the office with us and being nearby so the doctors could talk to her, which was amazing. And that was one simple conversation, one simple solution. Also, this here is that trust. Dr. Kingston gave me that trust from the very beginning. Trust that whatever you do is going to work. If you have the right people, the right intentions, and if you give people the freedom to be creative and do things that they think is right, you're on a good pathway. And also then just see those ripple effects if you do this. So yes, we did start in Frome, which had a place which has high social capital where there are people already doing things. An example of this ripple effect is in Frome, we helped set up a men's shed. As I say, that place where people can do carpentry side by side. In Frome, the young people said, we want a young people's shed. So they set up a young people's shed. The people who like technology said, we want to have a tech shed. So they set up a technology shed. Then the nearby town, Shepton Mallet, said, we want a men's shed in Shepton Mallet. And Glastonbury, another town, said, we want a men's shed. So these ripple effects are absolutely incredible to watch. So this is my final slide. This is just, we were doing some work on green social prescribing before COVID, but this is kind of, I've done a checklist, and this isn't a checklist saying you've got to do these things, but this is just a bit of a summary of the things that I've talked about. But the real basics there that I'm saying is, have you got trust? Has your system got trust? Do you trust that what you're doing is working? Do you trust that you can link up with each other? Find those people with energy and enthusiasm. Have you got a big vision? Remember in the beginning, it was just Dr. Kingston and me. It's just the two of us who kind of had this vision, but we tapped into the community. So it was the two of us tapping into the amazing things that were out there. And finding out who's keen. You know, we did this in the medical practice. We said, who's keen in this kind of work? And the caretaker said to us, I really want to get involved. So actually, you might think there aren't the people, but actually, do we ask? You know, we should ask, who wants to get involved? And really find out what's already out there. I'm sure many of the things I've talked about, you're thinking, we've got these in Sweden, we've got these in our town. Yes, you have. So is it what bit is missing, or is it not missing? Do you just need to shout about it a whole load more? And often people, when we do conferences, say, are these things sort of really well linked up? But that's, as I say, this is a kind of tick list of the things that, the projects that we've done, the staff that we've got, the training that we do, and that linking into that community support. It doesn't have to be what you do in Sweden, which it was just an example of what we did in Frome and in Mendip. So that's me. I think I might have whizzed through that rather quickly, a bit too quickly, but I hope that's okay with everyone.
Thank you so much, Jenny. This was so inspiring, and there are lots of questions being asked in the chat. A lot of people as well are asking if they can have your slides. Would that be okay if you, I think you might have sent them to us. Otherwise, please email them to us afterwards, and we'll make sure to post them on our site as well. I think the same rule for all these kinds of slides. There might be pictures involved where there's copyright issues, so don't use them for commercial purposes. People will post them, and you'll use them in your work. Can I just starting off this conversation, I think one thing I'd need to clarify again a little bit on the systemic level. You're saying you're not engaging volunteers as community connectors, but active citizens. Now, what to you? What is a volunteer? Because you're telling us that the active citizen is not paid. in your mind, what is a volunteer? Is that someone who is involved in an organization already? Is that the difference?
I think the issue was that because we only have a small amount of funding ourselves, we haven't got the management support to support 1,500 volunteers. We do work with volunteers. Volunteers can be trained up in that short 1 hour training. But when we say active citizens, it's because they don't have to have a police. In England, if you're called a volunteer, you have to have a police check. You have to have a role description. You have to have your travel paid for, except you have to be supported every 3 months. Mm-hmm. So this is just about people being empowered with knowledge about what's in their community and us spreading the words about what's in their community. So that's what I mean about, yeah, they're not paid, but they're also not formal. In England, we have some more formal volunteers. They could be more formal volunteers, but they're active citizens.
I see. Okay, now I explained it to me a little bit more. So one question that maybe Dr. Abel can answer as well, and you touched upon it, was how this model could reach out to more marginalized communities. You problematized it a little bit, saying it's easy to make community connectors be successful in an environment where there's already a lot of social activities, well-entrenched organizations, a thriving civil society. How do you go about doing this in more marginalized community where maybe the level of organizing is much lower? Can it work anywhere?
So the answer to that is yes, because this is something that happens all over the world. Community development happens wherever there are people, and we've got projects running. We know of projects all over the world, every continent, and it's just a facet of human behavior. And it's an interesting question about marginalized, because that's a recognition that some people don't feel part of the community as a whole. And the people who understand best what that feels like are people in those communities. And the key is about going to those communities and talking with people, see what matters for them, what's important, what do they need, what's already strong in their communities, and using that strength, how can the communities themselves come to solve the problems that they face, and how can we help that? And I know that Jenny's got examples of that.
There was one question asking, how long did it take for you to reach where you are now? Like how long did it take until you had this frame of working? Is this something where you can expect to set something up and have results in a quite short period of time, or should you think, we will have results in 2 years, 3 years, 5 years?
I think with regards to the setting up of things, I think it's with the community development side of things, it's easy, and that bit of it wouldn't take that long. Embedding in if you wanted to embed it in the doctors, in the GP practices, that's the bit that would take longer, which Julian can talk about. But I think if a general practice in Sweden were able to employ a community development worker, we've done so much learning that we could share. I can share all the things that we've got, like the community connector training and anything there, really. So Julian, about embedding it in GP practices?
I think that this is about, it's probably not so helpful to think of this as, oh, I achieved this outcome, but to think about building continuous improvement. And for complex systems, the way that this happens is you do it by small steps, a bit at a time. And that you can measure things like what are called process measures, which are the different components getting in place. But in terms of, rather than thinking, oh, if we reach this level, we're therefore successful, it's not like that. It's thinking about how do we build continuous change and making sure that you're looking at that continuous change as time goes by. And if it's not working, then you have to figure out how you make it work. So I think you can set bold aims. I want to reduce hospital usage by this much. But then you know it's extremely complex to do it, and you have to pay attention to all the individual parts to make that all function. And so you look at all the individual parts to make sure they're in place, and you build continuous improvement.
Excellent. So building systems for continuous improvement and continuously improving quality, I think that's a key message. There was another question about hearing impairment. Is that a big cause for loneliness? Is that something that you encounter, and how do you deal with that particular issue?
It's one of my passions. Because I was working with a gentleman came to me and he said his brother was in the nearby county and he was in a care home and nobody was cleaning and retubing his hearing aids. So his brother had been left without anyone cleaning it for 3 months. And this elderly gentleman, took his brother's hearing aid, brought it to Frome, where a volunteer cleaned and retubed it and gave it back to his brother, and his brother could hear. So this gentleman, he's called Wally, he said, I don't want that ever to happen to anyone again. So we are training people up just to say, here are some videos on how to clean and retube hearing aids. During COVID, people aren't doing that. The volunteers aren't doing it, but there are amazing videos. So we think if we can train up people in the community just to signpost to those videos, it's not a solution to all of hearing loss and things, but absolutely, if we can just help a few people, granddaughters cleaning their granddad's hearing aid, but also there are problems with getting batteries and things like that at the moment. We set up a hearing support cafe where people could meet each other and meet voluntary sector organisations and get support with hearing loss. So it is one of my passions, because I think it's something that it's an invisible thing that in England doesn't really belong to anyone to support and look after. So it's one of my missions.
Thanks. There's one very interesting question coming up from Charlotta Schön. She's asking, as a social worker, we often encounter problems convincing staff in medical primary care that these issues are important to work with, because they tend to work with a much narrower definition of what healthcare is than you would normally apply as a social worker. What is the argument that they can use in convincing the primary healthcare center to use these methods that maybe social workers would find natural to work with?
Can I just jump in there? I think get Dr. Kingston to do a 10-minute video with them. But
I mean, I think that the key for that is to say, well, do you want to give your patients the best treatment? And then if the answer is obviously going to be yes, and then you can say, well, look, here's the best treatment, and that I think providing the background information, including the slides, the book, the Health Connections Mendip website, all of that the article that we wrote in the British Journal of General Practice, all of these things providing information so that people can discover for themselves. They need to that essentially this kind of goes back to what we were saying before, is that there are 3 reasons why people choose to change their views. The first reason is about reasoning and logic. People need information. The second thing is about emotion. I know this feels right. When you hear the stories of how people's lives have changed, you go, I know this feels right. And the third reason is inspiration. It's about you see or you hear something and you say, I feel so inspired by this, I'm going to do this. And when you're thinking about getting people on board, you have to appeal to all of those things. That stories help enormously, and one thing alone is insufficient. But the 3 of them together and making it personal, those are the things that make the difference.
Thanks a lot. I get a question here about how to measure support, because how to measure success, because unfortunately you might need to use measures of success to convince someone this is something that we should invest time, resources, staff resources. And Elin Fernstrand is writing, now in the COVID-19 situation where admission to hospital might be very much a different measurement than under a normal situation, given the extraordinary and very different situation that we encounter ourselves in. She was wondering, are there other measurements of success that you can use other than hospital admission?
I mean, I think you have to think about try and measure what's meaningful. And, you know, you're thinking about what is it you're trying to achieve. And so it may be, for example, social connectedness is something you want to achieve, and there are measures of social connectedness. It may be that you think that social connectedness is important in improving mental health, and you would measure mental health scores as well. But you have to think about what it is you're trying to achieve. Now, what I would add is that in the UK, and I don't know if this is true in Sweden as well, that the UK health system has been for the last 40 years under extreme financial pressure. And it's been managed in a pretty vigorous and at sometimes hard-hearted way, which has meant that irrespective of what the rhetoric has been about, this is what we're trying to do, the reality on the ground is that there's huge financial pressure applied to the managers and the commissioners and the people who provide services within the system. And that means that when you're talking to people who pay for healthcare, whoever that is, you have to deal with the financial issue. And if you provide people with the best treatment, the cost of healthcare goes down. And if your aim is to persuade the people who pay for healthcare, that if you really want to persuade them, measure the cost of treatment and see it drop.
It's a very, very good piece of advice. I see people here write in the chat that I'd say you'd have probably similar problems, but in a different way. In the UK, we have social care and elderly care being the responsibility of municipalities, 290 entities across Sweden, and healthcare, including primary healthcare, being the responsibility of 21 regions. So there's always a problem of connecting, and there are patients and elderly people and lonely people who are stuck in between the responsibility of the municipality and the responsibility of the healthcare providers in the region. But I get in the chat all the time good examples of there being agreements signed to deal with these situations. So there's hope, and we will continue to discuss that as well later on this afternoon. So there's also, I get in the chat people mentioning projects that use social prescribing as a concept, where you would get prescribed social activities instead of medication or in addition to medication. I'm just scrolling here to see if I have missed any question that was asked, just to see.
Can I just talk about, somebody asked earlier on about social care and whether it affected social care.
Yes, please.
When we invited in that adult social care worker to work with us, because our team and all the doctors were empowered with the knowledge of what social care did, and we could go and speak to somebody, the referrals to adult social care reduced dramatically. In England, some people have to wait sometimes for 6 months to get an assessment for their home, or if they're not considered a priority. So what we were doing as a community is we were making inappropriate referrals to social care. And actually, when we knew we could ask questions like, do you have savings of under 25,000? If they said, yes, we do, we could signpost. If they had more than that money, we wouldn't signpost them to the social care people anymore. So it had a huge impact on the number of referrals to social care, because we were stopping it and helping those people before they had to wait on the phone line for 6 months. I mean, not on the phone for 6 months.
Because you could refer them to a community connector instead? And
just because it's sometimes it was very simple things that people were waiting a long time to get sorted. And actually we could get it sorted far more quickly. So they stopped using that referral through to the telephone line and started putting social care workers in other GP practices. So they actually changed the way they worked.
Mm-hmm. That's excellent. So I'm asking now the participants if there are any additional questions that you would like to ask. Just don't hesitate to put them in the chat or to repost them in the chat if I have missed any questions in Swedish or in English. Because as you know, the plan is that we would move on from this section in English to a section in Swedish with 2 Swedish examples of this kind of work, also to be inspired to see how we can bring this home and implement it in the Swedish context. So does anyone else want to ask a question? I want to repeat as well that we are very happy that you made such thorough presentations, and we're very happy that we can share them. And we want to refer people again. We will connect the links that you have mentioned. Also, Julian, you have written extensively about this. There are a number of scholarly articles that have been published in peer-reviewed medical journals. We will share them as well, but for those that might not find them very accessible, there is a book as well that we can recommend as reading. I see there's Linda Carlson wants to ask, what is the difference to compassionate community approach and ABC? She's writing,
okay.
Yeah.
Yeah.
You know?
ABCD, asset-based community development, and that's in one of the most significant organisations doing that is run by Cormac Russell, and Cormac and I
yes.
get on really well, and they're different ways of talking about the same thing. You know, there is a difference in terminology, but otherwise we are absolutely talking about the same thing. And I think that in the context of compassionate communities and combining it with medicine, that we've worked out some very specific things about how you do that with medicine. But I would say that there is a hair's breadth of difference.
And I think in asset-based community development, because when we started off, we didn't have a label or a theory or anything like that behind it. It was just like 30 years of experience of community development and working with people who had done similar things. But I think with the asset-based community development, I think they use more the kind of community activists, like sort of people who are trained up to sort of see what their community wants and things. Whereas ours, what we're doing here is kind of like getting everybody involved in a movement, and so that we don't have there are the individual people out there anyway, but it's very similar, but yeah.
Excellent, very good. See, now I have a new message here. Yes, yeah, so they were saying to clarify.
Lisa's frozen. I think she was saying to clarify ABCD, asset-based community development.
Clarify, so the A. It's good.
I think maybe somebody's not got their microphone muted and there's a background noise which is stopping other people hearing.
Okay.
Don't know.
No, it's better now.
Okay.
Yes. Thank you. Nu har jag tagit bort den här. Jag var nämligen uppkopplad till now.
Julian, can you hear Lisa?
I can't hear Lisa.
Yeah, I can now. Sorry, okay. I was muted. Sorry for this. Sorry for this. Incoming phone call from a child of mine who felt lonely, apparently.
Oh, I see.
Sorry for this. My internet connection on my cellular phone was by accident. Sorry about this. So I think we would draw this now to a conclusion, because we have we need time in the afternoon also really to take this down to the Swedish reality, to the Swedish complex context of municipalities and regions and healthcare centers and our civil society and our prospective community connectors as well. So thank you so much for sharing your time, for sharing your expertise, for your slides, and for your beautiful and inspiring examples and stories. We're so happy that you were able to join us this afternoon, and we're really looking forward to staying in touch. And I think you can expect now a lot of people will sign up for coming to visit you and keeping in touch and inviting you. So let's hope that we can soon meet in real life as well. Yeah. Thank you so much.
That would be wonderful. And it was lovely to have the opportunity of talking to you all, and I wish you all the best with your project.
Lisa, can I ask something? Is it possible that we can turn everyone's cameras on just so we can say goodbye to everyone?
Oh, I don't know if the host can, but maybe everyone can turn. Yes.
Yay!
Wow, that's a great idea. Nice. Hi, everyone.
Oh, that's lovely seeing people. Oh, okay. Thank you.
Bye.
Bye, everyone.
Bye. Wow. Nu får vi ni vill alla vara kvar här, eller hur? Nu ska jag lämna över till Kerstin som ska hålla i nästa del här. Och jag passar på att tacka så mycket för mig. Jag kommer att sitta kvar här i bakgrunden som er andra och lyssna. Jag ser fram emot att från Arena Idés sida fortsätta att följa den här frågan och vara en slags del i det nätverk som sammanför olika organisationer och initiativ som jobbar med ofrivillig ensamhet. Jag ser inte Kerstin framför mig.
Nej, min bild är borttagen av Kalle och Isabella.
Ja.
Jag kan inte få igång den själv.
Då ska vi se.
Nu tror jag att det går.
Nu ser vi dig, Kerstin. Däremot så ser vi också Helen Andersson. Har du möjlighet att stänga av din kamera? Det var en väldigt fin bild med en liten bebis. Fantastiskt. Också inspirerande. Jag lämnar över till dig, Kerstin. Varsågod.
Tack Lisa. Nu är det dags för panelsamtal och då vill jag välkomna Elin Fernstrand och Anna Sjösten.
Tack så mycket.
Hej. Elin, du jobbar ju som psykolog på en vårdcentral i Norrköping.
Jajamän.
Ja. Och jag vet att du och dina kollegor är inspirerade av Frome-modellen och har påbörjat ett slags pilotprojekt med inspiration från den här modellen. Skulle du vilja berätta lite grann om dina reflektioner från föreläsningarna och hur du tänker hur ni ska göra ert projekt och vilka delar som man kan tillämpa här?
Ja, jag tänker att det har varit jättevärdefullt att lyssna idag, för på något sätt så är det som att alla de här olika små delarna som man har klurat kring är så snyggt uppradade här, slutade till och med en liten checklist. Vad vi försöker göra är att vi ligger liksom fortfarande i startgroparna för vårt projekt, och det är jag och 2 kollegor till mig som liksom är den arbetsgruppen som har dedikerats till det här. Och vad vi nu precis har liksom börjat att dra igång är någon form av samarbete då med lokalt föreningsliv. Där vi senast i måndags hade vår första informationsträff med förhoppning att just förstå bättre vad de här föreningarna kan tänka sig att i någon utsträckning liksom hjälpa oss med eller vara tillgängliga för när det gäller hur vi då kan bemöta våra ensamma patienter, men också bli bättre på att som vårdcentral slussa dem ut till lokala föreningar. Så det är liksom fortfarande startgroparna på det arbetet. Och parallellt med det så håller vi också på att försöka undersöka förutsättningarna just för det här med hemsida som en viktig del av samverkan mellan olika grupper och föreningar, och också som ett sätt att på något sätt försöka få medborgare, oavsett om de är våra patienter eller inte, att vara inkluderade i det här. Eftersom det här med signposting är någonting som vi också tror hårt på. Att på något sätt nå ut till människor där de är och inte bara via enskilda kanaler. Liksom.
Hur har det gått att sälja in det här då och övertyga partners som ni vill samarbeta med till exempel? Jag vet inte om det är civilsamhället eller är det även socialtjänsten? Har ni fått med dem? Och hur har det gått?
Vi har börjat med att vi insåg att om vi fortsätter tjafsa längre med det här och bara tänka på det som idéer, så kommer vi liksom ingenstans. Vi måste bara börja i en ände och vara lite modiga. Så mina kära kollegor sparkade mig lite i baken, och så bestämde vi oss för att titta på en föreningslista från Norrköpings kommun med 200 föreningar. Försökte hitta en spridning mellan åldersgrupper och olika typer av inriktningar av föreningar. Ville pinpointa ett gäng som ändå hade att göra med frivillig verksamhet på olika sätt, för att jag tänkte att där fanns värdefull kunskap om lokalsamhället. Liksom. Så det är allt ifrån en fiskeförening som har jobbat jättefint med att inkludera personer vid Strömmen i Norrköping och ha liksom en social kontext kring det, till allt ifrån vävstugor till kurser och sådär. Och responsen har varit utifrån vad jag hade förväntat mig. Jag var liksom stålsatte mig för att det kommer kunna bli ett stort nej på det här, men den har varit jättefin och vi har fått massor med positiva hejarop och ser väldigt positivt på att också engagera ännu fler.
Mm. Men vilka utmaningar ser du kring att om man skulle försöka göra den modellen så mycket som möjligt, tillämpa den i en svensk kontext med det samarbete som det innebär då mellan primärvården, socialtjänsten och civilsamhället och kanske andra aktörer. Vilka tänker du är de största utmaningarna?
Jag sliter lite själv som projektledare på något sätt med insikten om att om vi tar det här som hemsida till exempel, där vi ändå kan konstatera att man i Mendip liksom har det som en väldigt viktig informationshubb, inte minst för personalen. Det måste vara lätt att göra rätt som läkare. Det ska gå snabbt att som sjukgymnast få tillgång till alla de här olika sakerna som man kanske bara vill skicka med en patient i slutet av ett redan rätt så tidspressat samtal. Liksom. Och att också skapa en informationsplattform där det blir lätt för både patienter och medborgare i övrigt att få tillgång till den här informationen känns väldigt liksom grundläggande, för att om vi hela tiden säger att vi vill nå ut till människor så måste vi ha någonstans att peka dem till. Och här har jag liksom inlett en konversation med Norrköpings kommun till exempel kring hur skulle man kunna göra en aktivitetsplattform där det blir tydligare vad som finns och också samla föreningsliv på ett sätt som blir mer visuellt för personer. Men där det väldigt lätt blir så att kanske ingen riktigt vill äga projektet, eller det finns massa olika lagbestämmelser eller snårig juridik kring vad får man inte lämna ut, vem står för den IT-utvecklingen, vem ska äga den här informationen och sådana saker. Och att det ofta finns rätt så vattentäta skott när det gäller vem som ska äga vilken plattform av säkerhetsskäl till exempel. Och det är en del av de där sakerna jag stångas med just nu.
Och Anna Sjösten, skulle du vilja presentera dig för publiken?
Absolut. Jag vill börja med att säga hej till allihopa. Även om jag just nu bara ser 2 stycken, men ändå så vet jag att det finns fler bakom så att säga. Och bara just det faktumet gör mig väldigt, väldigt glad. För att någonstans nu när jag har suttit här och lyssnat in både Jenny och Dr. Julian, så är det ju samverkan och att människor har en arena att på något sätt mötas. Så verkligen stort tack till dig också, Kerstin, som initiativtagare till just den här konferensen. Jag heter Anna Sjösten. Jag jobbar som verksamhetssamordnare på en kommunal träffpunkt i Borås. Och bara för att ni ska förstå lite omfattning och bakgrund så har träffpunkten funnits nu i drygt 5 år. Och jag kan med glädje säga att vi nyligen nådde 1 miljon besökare som har passerat våra dörrar. Och det är ju helt galet. Jag tänkte säga att jag kan inte ens räkna så långt, men ja, ni förstår omfattningen. Det är ju helt otroligt. Vårt hus är 4000 kvadratmeter till ytan, fördelat på 6 våningsplan. Vi har totalt 25 kommunala tjänstemän som sitter här och jobbar med lite olika professioner, med lite olika ingångar. Vi har runt 45 stycken föreningar som på ett eller annat sätt bedriver sin verksamhet i vårt hus. Allt detta i grund och botten till förmån för att bryta ofrivillig ensamhet. För att det är det som vi gör här, fast på lite olika sätt. Men vi gör det tillsammans och i samverkan. Just för att återkoppla lite till den här Frome-modellen och den samverkansprincip som ligger till grund. Jag kan med både glädje och stolthet faktiskt säga att jag tycker att Borås har kommit långt i det arbetet. För att här har man politiskt valt att satsa på den här frågan som oerhört viktig. Och det är någonstans, tror vi, förutsättningen för att man aktivt ska kunna jobba just med att bryta ofrivillig ensamhet och isolering. För man gör inte det i sina isolerade öar. Vi kommer aldrig nå dem vi verkligen är till för. Och vi kommer aldrig kunna förstå den omfattningen som faktiskt finns. Bara lite kort så.
Tack. Vad är dina reflektioner nu efter att ha hört föreläsarna?
Jo, men det är ju just det att för att på något sätt kunna lyfta diskussionen om ofrivillig ensamhet så behöver man ha in alla aktörer i samhället. Och alla aktörer i samhället, oavsett om man är en förening, om man är en organisation eller om man är jag som privatperson, så behöver man få in den principen utav att alla ska känna sig delaktiga. Vi är här tillsammans och vi bär upp vårt samhälle tillsammans. Och det är också på de premisserna som vi faktiskt gör skillnad. Alla spelar en viktig roll i det här. Och det kan vi göra på lite olika sätt. Och det är väl den principen, just det här med, vi jobbar otroligt mycket med frivilliga. Nu kallar ju inte de det vare sig frivilliga eller volontärer, även om jag kan tycka att när vi pratar om frivilliga så handlar det lite om det som de kallar för en aktiv medborgare, så att säga. Och det är en jätteförutsättning för att vi ska kunna bedriva aktiviteter, för att man ska kunna komma till oss när som helst och bli bemött av en vän. För det är också en skillnad på en kommunal tjänsteman som jag i det här fallet är och representerar och en annan frivillig person. För den frivilliga är här och frivillig basis och vill göra någonting gott för en annan människa. Så att just det engagemanget och att få in så många krafter som möjligt som finns i samhället att tillsammans jobba för just de här frågorna, det är jätteviktigt och det har ju de kommit otroligt långt med. Jätteinspirerande att få höra.
Mm. Vilka utmaningar ser du generellt när man jobbar med frågan om ofrivillig ensamhet, oavsett vilken aktör man är?
Mm. Ja, det klassiska och det som jag nästan alltid brukar svara just på den frågan, för den kommer lite titt som tätt, men det är ju just här att det fortfarande finns det är så stigmatiserat, det är fortfarande så tabubelagt och jobbigt och tufft att prata om det. Jag tyckte att Dr. Julian sa det så bra, för att han sa det just det att det handlar inte bara om äldre människor i det avseendet, utan ensamhet det syns inte utanpå. Enda sättet att kunna göra det är om definitionen skulle vara att en ensam människa är en singelperson, en människa som står ensam. Men vad som försiggås inom en annan människa, det är ingenting som vi vet. De känslorna äger man själv. Och just de kunskapsluckorna, om jag så säger, att inte se på ensamhet som ett fenomen som drabbar lite udda kufar, för det är inte så. Det tror och det jobbar vi väldigt mycket för, att på något sätt komma ut med den här kunskapen, informera om ensamhet. Jag brukar ta som ett exempel att jag är lärare i botten i min profession. Och jag har stått i skolans värld och pratat om fantastiskt bra saker. Jag har pratat om psykisk ohälsa och vikten av föreningsliv, fysisk aktivitet och så vidare och så vidare. Men jag kan inte komma på mig själv någonsin att jag har nämnt ensamhet som en problematik och som någonting man behöver vara lite vaksam för. För att det kan drabba precis vem som helst. Och när det väl gör det så är konsekvenserna utav det väldigt, väldigt stora. De kan bli väldigt stora. Så stigmat kring ensamhet, det är någonting som jag tror. Och sen att det behöver komma ännu högre upp i alla organisationer om man verkligen ska satsa på det. Då behöver det finnas beslut från beslutsfattarna om att det är en prioriterad fråga. Där kan jag ju känna med vår verksamhet och de besluten som vi har att vila oss på att vi har fantastiskt stor tillit att verkligen prioritera, inspirera och jobba aktivt med de här frågorna. Vi har alla förutsättningar för att göra det.
Ja. Jag känner också att det här med stigmat och skammen kring ensamhet verkligen är ett stort problem. Och i det arbete som jag har gjort, när jag har gjort intervjuer till exempel med läkare och psykologer och socialarbetare, så är det många som säger att de känner sig inte bekväma med att fråga klienter eller patienter frågan om de känner sig ensamma. Dels för att man känner att det kan finnas en risk att man lägger skuld eller skam på den individen, att det är dens liksom fel att den är ensam, att den som frågar känner så. Men också väldigt många som säger att jag har ju ingen hjälp att erbjuda, och då blir det så svårt. Man vill inte fråga om man inte har en lösning att erbjuda. Och jag tror att det här är ett stort hinder för kanske många att liksom konkret börja arbeta med det här nu och till exempel screena för ensamhet. Hur tänker ni kring det?
Jag har funderat mycket kring det där, just som jobbar med att stå på en primärvårdscentral, och funderat över hur mycket man skulle fånga med screeningformulär, hur jag skulle kunna jobba med rutiner som fortsätter göra det möjligt för mina kollegor att fokusera på det viktiga, som ju någonstans Abel här var inne på, var att ändå ha ett samtal. Vad är det du upplever i form av subjektiv ensamhet, som också Anna var inne på? Det handlar inte bara om vem som är socialt isolerad, utan hur är det känns? Inte antalet kontakter du har i veckan, utan hur ensam känner du dig? Och jag tror att en screening skulle kunna vara jättevärdefullt för att få ett hum. Och ser man att någon slår ut liksom högt här, så finns det all anledning att rota vidare. Men jag tror samtidigt att det är väldigt viktigt under ett samtal att inte låta ett par liksom frågor som du har fyllt i tysthet i en enkät vara det enda som ger mig som kliniker indikationer på hur du har det socialt. Jag tänker också att själva samtalet liksom på något vis kring hur många kontakter du har eller hur god kvaliteten på dem är i sig kan bli en väldigt viktig del i att leda vidare till men vad är det du saknar för någonting, och att fokus kan föras från jag känner mig ensammast i världen till vad är det du längtar till, och att det då blir en handling och en rörelse i form av en liksom riktning mot lösning i någon utsträckning. Det är en svår balansgång det där, för samtidigt så vill man på något sätt inte heller vara den här personen som är lite för hurtfrisk och säger att det bara är att göra så här och så här, utan det liksom gäller att gå till mötes i att det här är en svår situation, och jag hör vad du säger, och att det är därifrån man sen måste jobba. Men jag tänker att det finns på samma sätt som det finns flera olika sätt att kommunicera vad som finns där ute i samhället i form av resurser, så tror jag också att det är väldigt viktigt att som primärvårdscentral fånga upp potentiell ensamhet, eller vad man ska säga, på flera olika sätt. Därför att vissa människor kommer aldrig kryssa i jag känner mig ensammast i världen i ett 3 frågor långt formulerat enkätsystem liksom.
Nej, precis. Det är också mitt intryck. Och läst olika intervjuer då med patienter då, som huruvida de skulle känna sig bekväma med att prata om det här med sin läkare. Och det är väldigt få som säger att de har den relationen till sin husläkare. Att de skulle kunna, det skulle inte alls kännas bra för dem att säga att de var ensamma. Och kanske även om läkaren frågade så skulle de kanske inte känna sig riktigt bekväma med att svara heller, utan då kanske flera som säger det kanske skulle kännas lite bättre att prata med distriktssköterskan om det, eller med en kurator, eller med min arbetsterapeut, eller det är mycket sådär. Det handlar mycket om vilken relation man har också.
Absolut. Och där tänker jag också på något sätt jag vill skapa så goda förutsättningar för mina kollegor som möjligt hela tiden att lyfta den här frågan. Men jag tror stenhårt på precis det här du öppnade med, Kerstin, att om jag ska våga ställa den här frågan så vill jag också kunna veta att jag är kompetent nog och framförallt har resurserna för att ta emot svaret. Liksom. Att det är väldigt, väldigt viktigt att så här, nu ska vi upptäcka hur ensamma alla människor är, men då kommer det med det också ett ansvar att så här, hur kan jag hjälpa dig med det här? Liksom. Och det är där jag tänker, det här lilla versus det stora. Jag hör att Anna, er verksamhet har varit igång hur länge som helst. Jag tänker det låter helt fantastiskt. Och att jag tänker att det där är riktningen som vi vill och som vi vill jobba mot. Och att jag tänker att samtidigt att gräva där jag står och att börja i en ände är det enda jag kan göra. Och att samtidigt försöka vara lyhörd för vad är det mina kollegor efterfrågar och vad är det deras patienter framförallt efterfrågar. Och vad är det deras patienter efterfrågar när man har frågat inte bara en utan ett par fördjupande frågor kring det också.
Vad tänker ni kring det här motiverande, det här individuella stödet som man får genom deras lotsar, community connectors, hälsolotsar? De har ju väldigt viktig roll i Frome-modellen och som de säger, det är ju för väldigt många så räcker det ju inte att få veta vilket utbud av aktiviteter och grupper det finns, utan det handlar ju om så mycket, mycket mera. Man kanske har varit isolerad länge och helt tappat självförtroendet för att vara i sociala sammanhang. Och hur tänker ni att man kan jobba med det? Och vad tror ni om vikten av just det här individuella stödet?
Jag tror att det är otroligt viktigt, för precis som du säger, Kerstin, har man varit isolerad eller upplevt en ensamhet ganska så länge så börjar det också sätta sig på andra funktioner men också förmågor inom sig själv. Man tappar kanske en del av sitt självförtroende, självkänslan får sig en törn och man vet inte längre hur man ska agera i sociala sammanhang. På det sättet rent konkret som vi jobbar med den frågan här så skapar vi förutsättningar för möten i form av aktiviteter. Det kan vara cirklar, det kan vara matlagningsgrupper. I princip allt ifrån det lilla till det stora och väldigt, väldigt brett. Och sen så försöker vi fysiskt själva vara ute väldigt mycket och marknadsföra. För att man ska kunna få det här personliga samtalet en liten stund. För att vi har sett det att det hjälper inte att bara lämna över en lapp till en människa och säga kom på det här. Hur roligt det än må vara så finns det ingen där som möter upp mig när jag kommer. Och det finns heller ingen som kommer sakna mig om jag inte gör det. Och där försöker vi jobba väldigt mycket med frivilliga. Så att på varje aktivitet som vi skapar eller föreläsning eller vad den må vara så har vi alltid frivilliga kopplade till oss. En del av de frivilliga har gått en särskild utbildning. Och det är någonting som vi för 2021 hoppas och planerar att kunna satsa på ännu mer. Just för att man ska som frivillig person veta om att vi står för det här att motverka ofrivillig ensamhet. Människor som kommer hit oavsett om de kommer i egenskap av att de känner sig väldigt ensamma eller att de kommer för att de så gärna vill utöka sina sociala sammanhang. Så ska man som frivillig person kunna möta upp var och en av dessa individer och också försöka boka in en eventuell ny träff, en kopp kaffe eller liknande. Så att en person skulle kunna komma till oss initialt på grund av att träffa mig på en kopp kaffe. Där jag kan berätta om hela huset och allt fantastiskt som går att göra här. Men sen, det är där vi tänker att antingen så kanske man slussas in till en förening som vi ser som vår förlängda arm i huset. Eller så får man den kontakten med en frivillig. Så tänker vi kring den frågan.
Och vi håller på att kolla på lite olika lösningar där också. Vi har vissa personer i vår personalgrupp som mycket väl skulle kunna tänka sig att vara både den som har de här samtalen som ofta har motiverande samtal som någon slags grundläggande struktur. Alltså vad är det du vill mot och vad är hindren för det? Alltså att man faktiskt också uppmärksammar rätt så påtagliga hinder ibland i form av att jag kommer inte ens utanför mitt hem för jag har inte möjlighet till färdtjänst eller vad det nu skulle kunna vara. Kan ändå inte riktigt ta mig till de här aktiviteterna dit jag vill. Och att det är någonting som man i sig då måste belysa först. Men att vi också tänker att den här personen eller de här personerna i någon utsträckning kanske skulle kunna följa med till aktivitet. Att vi har ett nära samarbete med åtminstone ett gäng föreningar där vi också vet att här finns en kontaktperson som vi kan höra av oss till och se till att någon just kommer och möter på parkeringsplatsen som Anna var inne på där. Och parallellt med det så tänker vi oss än en gång att för att försöka få det här att bli så storskaligt som möjligt, kunna hjälpa så många som möjligt, så skulle det vara suveränt att se till att det här i så stor utsträckning som möjligt blir självrullande, för att det finns en person som känner att det finns något meningsfullt i att vara den som hjälper till att ledsaga en person till exempel till ett nytt sammanhang och sådär. Och vad som känns svårt i det här sammanhanget, både utmanande men också så väldigt häftigt med Frome på något sätt, är ju att vi pratar om en struktur, vi pratar om jättevitala och viktiga förutsättningar för att man ska kunna göra det här på en vårdcentral, och jätteviktigt med kommunikationen mellan olika aktörer. Men det som är så tokkoolt där är ju verkligen att de har lyckats få så många civila människor att engagera sig på ett sätt som gör att det här är liksom, ripple-effekterna har inte bara att göra med deras organisationer längre.
Ja, det var precis det jag tänkte också komma in på lite grann. Som jag tyckte var så otroligt inspirerande att höra när jag hörde om det här från första början. Att även personer som har yrken, typ frisörer och kafébiträder, eller brandmän eller poliser, alla yrken när man träffar mycket folk, hade ju fått åtagit sig som ett litet extra uppdrag bara, liksom utöver sin tjänst. Att när de ändå träffar personer och kommer i samtal med människor, så kunde de hjälpa till då att lotsa dem och göra någon slags like-version av den här community connector. Det skulle vara intressant att se hur det skulle fungera i Sverige, om det skulle finnas intresse för olika yrkespersoner. Vad tänker ni om det?
Jag tror att det hade kunnat vara något riktigt bra att satsa på, just för att man ska kunna nå så många som möjligt. För att återigen, det känns som att hur man än vrider och vänder på det så kommer man tillbaka till en gemensam nämnare, och den är samverkan. Jag kan ta ett väldigt kort exempel på när det rent konkret har sett väldigt bra ut just när det gäller samverkan. Julafton förra året så bestämde vi oss här på Träffpunkt Simonsland att vi ville ha öppet i någon form. Men vi kommunala tjänstemän jobbade ju egentligen inte på julafton. Vi har gjort det sedan tidigare, men vi tänkte att vi måste se om vi kan göra detta på något annat sätt. Så vi kopplade in både frivilliga och vissa föreningsrepresentanter, satte samman dem till en grupp, gick igenom lite kort hur vårt café, vårt kök fungerade. Vi har i vårt uppdrag från politiken fullmäktige att vi får samverka med bland annat näringsliv, vilket gjorde att vi sträckte ut handen till, i det här fallet då, Willys i Borås. Så på självaste julafton, 4 eller 5 timmar, så drev föreningar och frivilliga vårat hus. Vi kunde bjuda på mat från Willys. Vi kunde bjuda på julklappar till alla de 50-talet som faktiskt kom den här dagen. För att civilsamhället och näringslivet hade gått in och sponsrat med julklappar. Och de historierna, lite apropå som också Dr. Julian Abel pratade om, att det är stories, det är ett sätt att mäta det. Vi kan lyssna in, vad säger människor? Har vi på något sätt kunnat hjälpa en människa som upplever en hög grad av ensamhet? Jo, men vi kan prata med dem. Och de historierna som vi fick efter att vi hade öppet då på självaste julafton, helt och hållet utan kommunal inblandning, och det är ju det som är så häftigt, de är helt fantastiska. Och det var verkligen hela spannet, från små barn som var här med vårdnadshavare till äldre seniorer till oss, de någonstans mitt emellan. Och tänker man på det sättet så ser man ju också vilka enorma krafter det finns i samhället. Det känns ju hoppfullt. Vi kommer ju liksom greja detta. Det är klart vi kommer göra det, men vi kommer göra det tillsammans. Tack.
Tack till er båda för att ni bidrog med era reflektioner. Nu så säger jag till alla deltagare att det blir 10 minuters paus. Och under den pausen så kommer att ni att förflyttas till de här mindre diskussionsgrupperna. Och sen kommer ni att prata i de grupperna fram till 3:55. Och då återsamlas vi, då flyttas ni tillbaka till det här huvudrummet. Så kör vi lite avslutande ord där. Tanken var att ni skulle delas upp enligt regioner, och jag tror att det har gått till viss del, men alla hade inte era riktiga namn uppe i i skylten där. Så att det var lite svårt att hitta alla personer och placera dem i rätt grupp. Men det är i alla fall, alla kommer i alla fall komma i en grupp med en samtalsledare.